Coming up on ALK News Network, we explore novel agents for ALK-positive lung cancer and nivolumab in kidney cancer. Next, we'll talk to Dr. Leonard Gomella about the final results of the Q302 study of abiraterone and prostate cancer. We'll also be hearing from experts from the Dana-Farber and Columbia University about the spectrum of care in lung cancer. All that and more starts right now on ALK News Network. Hello and welcome. I'm Laura Jones.
And I'm Tara Petersen.
In lung cancer news, the highly selective ALK inhibitor AP26113 has been granted breakthrough therapy designation by the FDA for treatment of patients with ALK-positive metastatic non-small cell lung cancer who have received prior treatment with crizotinib. In the phase 1-2 study that led to the new designation, the objective response rate in 72 evaluable patients was 72%. One of the distinguishing features of these results was radiographic improvement in almost 2/3 of patients with brain metastases, which is a common site of treatment failure. The median duration of response was 49 weeks and median progression-free survival was 56 weeks. Among those who had already received crizotinib, the overall response rate was 69% and median progression-free survival was 47.3 weeks. In the 7 patients who had not yet been treated, AP26113 demonstrated 2 complete responses and 5 partial responsive for an overall response rate of 100%. A phase 2 study looking at the 90 and 180 milligram per kilogram dose will hopefully address the problem of early onset pulmonary symptoms that were present in 10% of patients taking a higher dose of the drug.
In other news, a collaboration between Novartis and BMS will result in several clinical trials involving the PD-1 inhibitor nivolumab and targeted therapies against ALK, c-Met, and T790M for patients with non-small cell lung cancer. 3 phase 1-2 clinical trials will be launched as part of the collaboration. In the first study, nivolumab will be combined with the ALK inhibitor ceritinib, which was approved earlier this year for crizotinib-resistant ALK-positive non-small cell lung cancer. In the remaining studies, nivolumab will be explored with a c-Met inhibitor and an EGFR T790M targeted therapy.
Also in the news concerning nivolumab, results of a phase 2 trial now confirm robust activity in patients with metastatic renal cell carcinoma. In the study, patients received nivolumab at doses ranging from 0.3 to 10 milligrams per kilogram. At the 2 milligram per kilogram dose, the median progression-free survival was 4 months, and the median overall survival was 25.5 months. The overall response rate was similar for all 3 doses at around 21%. Overall survival for patients who were heavily pretreated was 18.7 months versus not reached for those who were treatment naive. A phase 3 study is currently comparing nivolumab at 3 milligrams per kilogram to everolimus following anti-angiogenic therapy.
The treatment of patients with non-small cell lung cancer is rapidly evolving with the advent of next-generation targeted therapies and novel immunotherapies. For perspective on these advances, we interviewed Dr. Balazs Halmos from Columbia University Medical Center.
And actually our team has been at the forefront of understanding mechanisms of resistance, which in about half of the patients includes the development of a new mutation in the EGFR protein, which basically leads to the protein not allowing good binding of the medication into the receptor any longer. So simply the key doesn't fit the keyhole any longer. And based on that understanding, new medications have been developed, and these are now the 3rd generation EGFR inhibitors that are very specifically targeting this very special gene mutation that occurs in about half of the patients receiving the 1st generation medicines. And our good fortune is that these medications don't just target this resistance mutation very well, but they also do not interfere with the function of the normal type of the receptor, which is actually very important for the maintenance of our skin and the maintenance of the health of our gut.
The leading 3rd generation EGFR inhibitors in development are ruxolitinib, previously known as CO1686, and AZD9291. Both of these drugs have received breakthrough therapy designations from the FDA for their potential as treatment for patients with T790M positive non-small cell lung cancer.
We're facing a situation that we have these novel exciting agents which potentially could be more effective than the medicine that we have in clinic and are also having less side effects. So this is a very good situation for patients specifically, but also for us medical oncologists, as we want to give our patients not just the longest life expectancy, but the best quality of life. And here at Columbia, we have some of these key studies open with these novel EGFR inhibitors. In fact, the last number of months we've been very, very active enrolling patients into these key studies and are going forward with studies in the coming weeks now, not just seeing if these medications can work after the first generation drugs stopped working, but looking at studies where we're comparing the two sets of agents with the hope that these novel medicines can be brought into the frontline setting to be given to patients at the time of diagnosis with the hope of long-term success.
At the Dana-Farber Cancer Institute, investigators now hope to add on to EGFR inhibition using immune checkpoint inhibitors targeted against PD-1 and PD-L1. For an inside look into trials investigating this approach, we sat down with Dr. Leena Gandhi.
Right now there are actually combination studies coming of PD-1 and PD-L1 inhibitors with erlotinib. Two of the trials I mentioned, one of the trials I mentioned, the pembrolizumab study in combination with chemotherapy, first-line therapy, is also one of the cohorts is in combination with erlotinib for first-line EGFR patients who have never been treated. Their standard first-line therapy would be an EGFR tyrosine kinase inhibitor such as erlotinib. This trial would be the opportunity to get both of those drugs together. We don't know as yet whether those drugs will be different or better, and I think they would primarily be used for patients who have already had targeted therapies and have progressed on those therapies and need to be treated with newer therapies. But I think there's certainly the opportunity for combination therapies on coming trials as well that might be good opportunities to be treated earlier in the course of cancer. There is data from Kwok Wong at our institution that suggests that for certain oncogene-driven cancers, they may be more reliant on PD-L1 biology. So EGFR-driven tumors in mouse models seem to have higher levels of PD-L1 expression. And in mouse models, PD-L1 inhibitors were very effective in that scenario. We don't know yet whether the same is true in people. That's certainly an active area of investigation. I think there's also the thought that because targeted therapies really are mostly cytostatic drugs, really what we think of them as doing is giving us very good responses that last for a time, but they're ultimately cancers develop resistance against them. So they're very good at debulking tumors and giving a very good response initially, but we'd like them to last a lot longer than they do. Even though they last longer than chemotherapy, they still don't last long enough. And what we hope is that what immunotherapies might add to that equation is a consolidation of that debulking to a longer lasting, more durable response from the targeted therapy itself. If you activate the immune system to sort of really keep those tumor cells from growing, you might prolong some of the durability of that response and maybe delay the emergence of resistance. Now that's pure speculation, but I think it's something that hopefully some trials coming will help us answer.
Up next, we go one-on-one with Dr. Leonard Gomella from the Kimmel Cancer Center at Jefferson University in Philadelphia.
In a recent interview with Dr. Leonard Gomella at the Kimmel Center at Jefferson, he discussed the final results of the Phase 3 COO302 study that were just presented at the ESMO meeting in Madrid.
This was the long-term study of the abiraterone 302 trial that looked at the use of abiraterone before docetaxel chemotherapy in men with metastatic castrate-resistant prostate cancer. And this long-term data showed convincingly that there was a benefit to using abiraterone with prednisone in this patient population. What was very important about the study is that the final analysis was about a 34.7-month survival in the treated group versus about 30.3 months in the placebo arm of the study, which was just prednisone. So this convincingly shown that there is a survival advantage to using abiraterone in this patient population. In this particular Cougar 302 study, there was a crossover. About 66%, or about 2/3 of the men in the treatment arm, and about 80% of the men in the placebo arm ended up crossing over to the abiraterone arm, so they ended up getting actual treatment. What was very important about it is that regardless of whether you were in the treatment arm or the placebo arm, the fact that the subsequent treatment really did not make a difference. The results held true that the use of abiraterone did extend the survival even in those that were in the crossover arm. Concerning starting the use of these agents for metastatic castrate-resistant prostate cancer, we probably like to start them within a month or two. Sometimes, 3 or 4 months can make a difference, so you want to try to get these agents on board as early as possible. The take-home messages of using the abiraterone in these patients is that really a lot of it has to do with quality of life and survival. Some of the benefits in this particular trial of using abiraterone really related to the delayed use of opioids, sometimes as long as possibly as 12 months or longer, meaning that men are not having discomfort, they're not suffering a lot of morbidity from prostate cancer, and their quality of life is greatly improved. So it's good that we now have these agents that we can use in patients that are relatively well tolerated. Side effects profiles are really very, very limited. You do have to monitor liver function tests and some basic chemistry parameters, but overall the drugs are very well tolerated and give a good quality of life to men who have an otherwise very difficult situation.
Dr. Gomella further discussed how the Cougar 302 results have impacted standard of care.
Well, abiraterone is already used in the two settings. It was initially approved in the post-chemotherapy setting, and in 2012 was approved in the pre-docetaxel, pre-chemotherapy setting. So medical oncologists and urologists are already using these agents. I think what this study really does show is that, in fact, there is a convincing long-term survival. So these agents are used, very commonly used, and again, very well tolerated. So I think this particular study over the long term, this 4-year end of Cougar 302 study, really did give convincing data to those that were not believers in the benefit of abiraterone, that truly was a significant survival advantage.
We later asked Dr. Gomella to expand on the approval of enzalutamide as a treatment for men with chemotherapy-naive or metastatic castration-resistant prostate cancer, and his use of abiraterone versus enzalutamide in a newly diagnosed patient.
We now have 2 drugs that are improved oral agents in the pre-chemotherapy and the post-chemotherapy space, both abiraterone and enzalutamide. And the enzalutamide was just approved in the pre-chemotherapy space in September of 2014 based on the PREVAIL study showing approximately 29% improvement in survival of these men. So when you make a decision between enzalutamide and abiraterone, a lot of it comes down to the clinician's comfort level with the drug. There are some subtle differences between the two. Abiraterone does need to be used with prednisone, where enzalutamide does not require the use of prednisone. Some of the monitoring issues, you have to monitor liver function tests, for example, and potassium levels with the abiraterone because of the risk of hypokalemia and hypertension. There are some contraindications which are on the label for abiraterone, such as very severe liver insufficiency. Enzalutamide actually, oddly enough, only has the contraindication of pregnancy when you look on the label. However, there is always a caution with enzalutamide. There's always a lingering concern about seizure risk, and although it's not been a recent problem, there is some early data that suggests that patients who do have a prior history of seizure, you should have some caution in using enzalutamide. So I think at the end of the day, what happens is each physician has a comfort level of using the different medications, and they try to look at some of the specific characteristics of the patient in deciding which agent to use. Recently, there was a study looking at something known as the ARV7 splice variant. There was work done at Johns Hopkins looking at circulating tumor cells, and the presence of the splice variant was able to determine whether or not abiraterone or enzalutamide had a good clinical response. And it turned out that the splice variant was present. The drugs did not appear to adequately interact with the circulating tumor cells in this particular study, therefore suggesting that the presence of the splice variant may indicate these drugs may not be effective and you may want to go to another agent. This is very exciting because we're getting down to the level of precision medicine, and the best we can do is try to predict the patient's response to these different drugs. So having a marker like ARV7 splice variant as a responsiveness or lack of responsiveness marker for these agents is very exciting, and hopefully at one point will find its way into routine patient care as larger data sets become available and validate these findings. What's happening now with all these new agents that we've had approved the last 3 or 4 years, what order do we use them in is going to be one of the big questions to ask. Certainly using things like the ARV7 splice variant to decide strategies, yes, no, for a oral hormonally reactive agent or using a chemotherapy will be important. But another unanswered question that we're slowly getting information on is the issue of the sequencing of the drugs or the potential for using drugs together in combination. And I think there's been very limited studies so far of this, but there are some larger trials that will be looking at the combination of abiraterone and enzalutamide, which will take many years to get the final results of, but at least it's being looked at.
I'm Laura Jones.
And I'm Tara Petersen.
From all of us here at ALK Live News Network, thanks so much for watching. We'll see you next time.